Yes.
So now over to you. You
you.
can go ahead. Yeah. Thank you.
Hello and a warm welcome. It's a pleasure and honor to be here with you all today. And I'd like to thank Dr. Bindukuti and the organizing committee for providing me with this opportunity. So today I'll be speaking about dental sleep medicine. So in my talk today, I'll be beginning with the epidemiology of dental sleep medicine, going over some recent updates in dental sleep medicine. Since oral appliance therapy is one of the mainstays of dental sleep medicine, I'll be speaking a little more on recent updates in oral appliance therapies. And finally, I'll be summarizing and concluding. So this was the data that was published by the American Academy of Dental Sleep Medicine. They did a consensus in the US with experts, and the data that is presented here is from 2014. However, in terms of percentage, I think a lot of this is still applicable. So the basic highlight of the graph is, if you look at the graph here, what you would see is about 80% of the population with obstructive sleep apnea is still undiagnosed, and only 20% of the population are diagnosed. And among the different treatment options that we have, lifestyle measures is advocated to 100% of the population, whereas for about 85% of the population with obstructive sleep apnea, Cpap is still the gold standard, like Dr. Chandrasekhar mentioned. Now, looking at the other options that Dr. Chandrasekhar had mentioned, primary among those is dental sleep medicine and oral appliance therapy. So oral appliance therapy is the second most common treatment modality that would be advocated after Cpap. So dental sleep medicine is an area of dental practice which basically focuses on use of oral appliance therapy to treat sleep disordered breathing, including snoring and obstructive sleep apnea. So especially in instances of snoring, a lot of patients present to the dentist thinking that there are dental alternatives which can help them. And on screening, a lot of patients may have symptoms of obstructive sleep apnea as well. So in dental sleep medicine, the dentists work together with sleep physician and identify best treatment for each patient. So the sleep physician is the center of treatment for the patient with obstructive sleep apnea, and a dentist works in cohort with them to identify the best treatment suitable for each patient. So Dr. Michael Glick, who was the previous editor-in-chief of Journal of American Dental Association, and who was my head of the department at Rutgers University in New Jersey, he has been focusing a lot on dental screening in medically complex patients. And he has been exploring the dentist's role in identifying medically complex patients. And a collaborative study that we did with them, looking at the dentist's role in screening and referral of medically complex patients in the Indian scenario, we found that dentists could play a significant role in identifying and referring patients to the physician. So in addition to screening and referral, the dentist may also be involved in sleep medicine when they are referred patients for dental sleep appliances or oral appliance therapy. Now, once the patient is referred for oral appliance therapy, we generally work with the sleep physician and identify best possible treatment for these patients. We also monitor and treat for potential side effects of oral appliance therapy. One of the major side effects of oral appliance therapy is temporomandibular joint disorders. And we monitor patients and we treat patients for these side effects as well. When we speak about the dentist's role, we have about 12 different specialties in dentistry in the US. In India right now, we have about 10 different specialties. So last couple of years, dental anesthesia and orofacial pain and TMD have been added as 2 additional specialties in dentistry in the US. So, however, these specialties are still to come to India. So in India right now, the scenario is that we just have a handful of people, a handful of dentists who are involved in dental sleep medicine. So in addition to these handful people who are trained in oral appliance therapy, we have multidisciplinary team involving oral maxillofacial surgeons. We involve different orthodontic specialties, and radiologists, oral radiologists are also involved in the multidisciplinary dental team. So earlier, when the specialty of dental sleep medicine started evolving, which was a decade back, the primary focus was mainly on management of management with oral sleep appliance therapy. However, now the paradigm is slowly shifting towards prevention, and that's where I'll be focusing a part of my talk. And this is to familiarize you with opportunities to identify people who could potentially develop sleep apnea, early intervention. So one thing is that the diagnosis of sleep apnea, obstructive sleep apnea, always rests with the sleep physician. So dentists are not involved in diagnosis of obstructive sleep apnea. That is with the physician, and we just work in cohort with the sleep physician to identify and treat these patients. So with a dentist, the sleep physician is the person who provides the diagnosis and the referral of patients. And when the patient is referred for oral appliance therapy or for treatment with dental sleep medicine, we use evidence, clinical expertise, and patient needs and preferences. And we generally communicate this to the physician. And once we have a talk with the physician, we identify best possible treatment for patients with obstructive sleep apnea. So like Dr. Chandrasekhar mentioned, the upper respiratory tract has a very important role in obstructive sleep apnea. And in addition to genetic and structural components that we are born with, physiological factors are added to result in obstructive sleep apnea. So it is not just structural deformities which can result in obstructive sleep apnea, but the patient has to be predisposed physiologically as well. So in dental sleep medicine, the oropharynx and the structures in the oropharynx are the major region where the dentists focus their attention. So when we're dealing with obstructive sleep apnea, we have the pediatric obstructive sleep apnea and the adult obstructive sleep apnea. And in pediatrics, in both these instances, dentists can play a significant role in prevention and both management options. So in pediatric sleep apnea, since the mandible is growing or the maxilla is growing, there are several treatment options which are done orthodontically, which can prevent obstructive sleep apnea or treat obstructive sleep apnea. So we have, as an orthodontist, we are involved in correction of the alignment of the upper and the lower jaw and different structures within the oral cavity, including the alignment of the teeth. So we have jaw expansion devices and functional devices which can actively grow either your maxilla or your mandible. In addition to that, we also have different curative strategies in terms of growth modification and increase in airway size. So in pediatric sleep apnea, there are several patients that have different syndromes like Treacher-Collins syndrome, golden heart syndrome, or in fact, even patients with cleft lip and cleft palate who could be increasingly predisposed to developing obstructive sleep apnea. So in patients with generally cleft lip and cleft palate, a combination of surgical interventions and a combination of orthodontic interventions can significantly help in closure of the palate and the lip, and it can be preventative for obstructive sleep apnea. A lot of these patients with different syndromes, if you're looking at the facial forms, what you would see is majority of them have a very small mandible, and some patients could have a very small underdeveloped maxilla as well. And because these are underdeveloped or very small in size, the way that the teeth meet, there is a lot of crowding, and the palatal shape and the shape in which the teeth are aligned is generally V-shaped. And because of this, there is often crowding of the teeth. And because of crowding of teeth, the space intraorally is very restricted. So an orthodontist and surgically, what we could do is we could align the teeth intraorally, and we could also use functional devices to expand the palate once the surgical phase of treatment is over. A lot of children have different functional habits, parafunctional habits as well, and predominant among them is thumb sucking. So what happens in a child is that with the pressure of the thumb placed against the palate starts curving upwards and it becomes poorly developed. So in a lot of instances, the palate, instead of being U-shaped and wide and normal, would become V-shaped and there would be a high palate. So this can also lead to dental crowding and development of obstructive sleep apnea as well. In addition to this, patients could also have mouth breathing habits or parafunctional habits such as bruxism. Bruxism is basically contact between your upper and lower teeth in parafunctional movements, and patients could have daytime bruxism or nighttime bruxism. Nighttime bruxism is now considered to be a sleep movement disorder. So in all these instances, it could predispose a patient to obstructive sleep apnea, and hence careful history and clinical examination is required for screening patients of obstructive sleep apnea. So generally, if you look at the palate in cases which are developing malocclusion. Malocclusion is when the arch is not nice and round and the teeth are placed not in proper alignment. So when that happens, you could use functional devices which break the palatal suture, and that causes slow deposition of bone in the space, and that slowly leads to expansion of the palate. So if you would look at the pre and the post pictures here, at 1 and 3, what you would see is by slow activation using a key, the device can slowly start pulling the palatal sutures apart, and there will be slow bone deposition, and this can increase the palatal width. With increase in palatal width, normally the teeth go into good occlusion. So if you're looking at this figure here, it's an animation basically showing how a palatal expansion device works. So by slowly inserting a key here and using the device, opening up the device, slowly you can open up the palatal suture and cause bone deposition and increase in width of the palatal size. So you can have palatal expansion devices which are fixed or which are removable. So in some instances, when the patients are very non-compliant, it is very hard to use a removable device. So using a removable device in several instances, the patients are non-compliant and they can take it out themselves. And a lot of children are very conscious, especially when they are in the school going age. So a lot of kids tend to take it out and not use the appliance. So in instances of non-compliance and better treatment prognosis, we do recommend fixed arch expansion appliances. And in this instance, they are cemented to the molars and the other teeth in the palate. And these are basically non-removable. So the patient basically has it in their mouth throughout the day and at night. So studies have shown that orthodontic treatments may be effective in managing pediatric sleep apnea and obstructive sleep apnea. So if you just see these two animations, what you would see is with increase in alignment of the teeth, there is more space intraorally. However, other outcomes such as neurocognitive and cardiovascular functions have still not been systematically studied to date, and we don't have data on those till date. So in addition, like I mentioned, to treatment, surgical and orthodontic treatment in patients with different syndromes and cleft lip and cleft palate, you could also have habit correction devices. So habit correction devices are generally advocated when different habits such as thumb sucking persist beyond the normal age, that is beyond 1 to 2 years. So we do get patients who are 6 years old or 7 years old and still have thumb sucking habits. And in that instance, we can use various habit correction devices to help these patients. So what you see here is a tongue crib. So some patients have the tendency to push the tongue out and or have thumb sucking habit. And in these instances, these cribs, which are like sharp projections, they dissuade the patient from putting the finger in. Again, in this instance, we have both fixed and removable options. However, in a lot of removable options, what happens is once the patient is familiar that they can take it out, kids tend to take it out and then start thumb sucking. And in those instances, we prefer fixed habit breaking appliances where we band the tooth and using different dental cements, we place them so that they are permanently fixed so that the child cannot forcibly remove out these appliances. Different appliances are also available for mouth breathing habits, because with mouth breathing, we also see similar palatal developmental forms where the arch becomes extremely constricted and it is very high, causing dental malocclusion. So both dental and skeletal malocclusions can be corrected in children with orthodontic and, if necessary, surgical management. So outcome studies looking at use of expansion devices have reported that between 50 to up to 100% of the patients could respond to expansion devices, and they are extremely helpful in pediatric obstructive sleep apnea. In fact, one of the studies which had a follow-up for up to 3 years showed that there is a 80% improvement with obstructive sleep apnea. So in pediatric patients following adenotonsillectomy, if there is residual obstructive sleep apnea, the first thing that we do is we take a comprehensive history and a comprehensive clinical examination. We also use different radiographs, mainly plain radiographs, to look and assess skeletal deformity or soft tissue problem. So if we feel that it is a skeletal deformity, we may need to use a combination of surgery and growth modification strategies. So in growth modification strategies, again, we look at whether it is a small constricted maxilla, or it is a small retruded maxilla, or it is a small underdeveloped retruded mandible. So basically, we look at both the maxilla and mandible, and we decide based on those. If it is a soft tissue problem, again, we look to see if it is just obesity or it's a combination of different functional habits as well. And at that instance, we may need to do both myofunctional therapy. Now, we dealt with patients with pediatric obstructive sleep apnea. The second category of patients that we'll be dealing with is adult obstructive sleep apnea. Now, with adults, the main thing that we need to remember is that the sutures, the palatal sutures, are already closed, and growth is no longer actively happening. So in patients with adult obstructive sleep apnea, the management strategies are either using oral appliance therapy, where we bring the jaw forward, or the other option is orthodontic therapy. But with orthodontic therapy, we primarily target alignment of the teeth and not changes in the structure of the jaw. The third option that we have is surgical management for adult obstructive sleep apnea. So if you're looking at these, this would be a classic case of pediatric sleep apnea with habits such as mouth breathing or with thumb sucking. In adults, it would develop into an arch which looks V-shaped, narrow, and there's a lot of crowding of teeth, if you would see. Now, following treatment, if it is done in childhood, you could achieve a U-shaped palate. However, once the palatal sutures are closed, then it becomes very hard to do it without surgery, just using myofunctional devices. So in adult patients, generally what is done is we use mandibular advancement. So first thing we do is we assess whether it's just maxillary deficiency or whether it's mandibular deficiency. And if it's purely mandibular deficiency, we would use mandibular advancement using surgical procedures such as sagittal split osteotomy, and that brings the jaw forward. So there would be increased intraoral space because of that. So a systematic review and meta-analysis looking at upper airway surgeries concluded that among the different surgical options, maxillomandibular advancement had best outcomes. And maxillomandibular advancement is where they make a split in both the maxilla and the mandible, and that is brought forward. Okay. Now, again, surgery may be accompanied by some adverse effects. However, compared to other major surgeries, the side effects were minimal. Okay, so this is again an animation showing how change in maxillomandibular relationship can increase the airway space. So in sagittal split osteotomy, where it's basically done for the mandible, just the mandible, there's a split created in the mandible, and the mandible is brought forward for this position. A similar thing could also be achieved by mandibular advancement devices or oral appliance therapy. So oral appliance therapy is a non-invasive modality which could be used temporarily to achieve advanced mandible position, whereas a sagittal split osteotomy is more of an invasive and permanent procedure which could bring forward the mandible. So in case the mandible is not very deficient and it's not extremely small, then you could just go on with the mandibular advancement device as opposed to surgical mandibular advancements. Okay, so if there is a retruded mandible or a very small mandible, you could also have maxillary advancement procedures where you create split in the maxilla and bring the maxilla forward to again increase. Maxillomandibular advancement basically deals with advancing both your maxilla and your mandible. Okay, so this is again an animation showing how mandibular advancement is done. Okay, and this is showing the same thing in animation. The thing that we have to keep in mind is the inferior alveolar nerve frequently is injured, and that's one of the most common side effects with mandibular advancement surgeries. Now, following this, if there is dental malocclusion, you could also combine it with orthodontic therapies. Now, the mainstay of dental sleep medicine is oral appliance therapies. And initially, when the field began, we were mainly concentrating only on oral appliance therapies. So among oral appliance therapies, so if you just Google, there are hundreds and thousands of oral appliance therapies that are available from on Amazon as well. However, the ones that I'll be dealing with are custom-made oral appliance therapies. So we have three different categories in that. One is titratable and one is non-titratable. Titratable means we can control the amount of advancements, and with advances in mandibular advancement devices, the increments in which we advance the mandible could be as low as 0.025 millimeters. Okay, non-titratable ones are made at a single shot and are not titratable. So you keep the patient in a fixed position. You also have tongue retaining devices, which were popular probably a decade back, but are no longer being used. And recently, you also have combination of Cpap and dental mandibular advancement devices. So mandibular advancement devices are currently most popular and they're most widely used. And all of these designs that you're seeing here, they're all titratable mandibular advancement devices. So you could have keys or elastics in the side, which allow titration of the device. So generally, the protocol is we bring the mandible forward by up to 50% of the maximum protrusion, and then gradually increase it on 0.025 to a millimeter increments, depending on the type of device that we have. Now, since these appliances are basically worn at night and we are bringing the mandible severely forward, the most common side effects that we see is strain on the temporomandibular joint and the masticatory musculature. So in addition to that, when these devices are used for a prolonged period of time, it could also cause occlusion changes or changes in the bite. And for these, to prevent these, we also have aligners that the patient commonly wears in the morning. So after use of mandibular advancement devices throughout the night, you have aligners that can be morning aligners that you put in the morning, and that kind of rests your temporomandibular joint and the masticatory musculature and allows the jaw to go back to its functional position. So like I mentioned, there are about 100 or 200 different appliances which are available on the market, and a lot of them are available without prescription and they're not custom made as well. But you need to be really careful about what kind of appliance the patient is using. So among mandibular advancement devices, these designs are the most common ones that are available in the market. Till a couple of years back, we did not have a lab in India, and these appliances had to be sent either to Australia or to the US to fabricate. We mainly were doing non-titratable kind of devices or devices with very low titration. But for the past 5 years, we've had this lab in India. and we are able to give very closely titratable devices. So what you would see are these hooks here. So this Herbst device and the Dream Tap are the two most common types of dental mandibular advancement devices that we use. And you basically have keys which you would insert here in the palate or in the side, and that you can use for titration and mandibular advancement. So like I said, you would start off at 50 to 60% of their maximum protrusion and slowly start titrating them upward. And you could also do a split night study to evaluate its efficacy and see if further titration is required. Generally, we go with patients' report with a lot of improvement in their daytime drowsiness and other symptoms. And in addition to that, you could also go in with a split night study using these devices. Okay, so this is basically, this looks like a pin, and that is inserted into these adjustment screws, or you could have it in front depending on the different type of appliance, and you could titrate these appliances. You also have different elastics that go on the side. This is the least titratable one, where you just titrate. It is a borderline device between titratable and non-titratable. And using elastics, you generally go in 1 millimeter increments. Okay. Tongue retaining devices were popular like a decade back. With efficacy, they're extremely efficacious. But the only problem is that, you know, it's really uncomfortable putting the device in the mouth. It's going to pull your tongue forward, and it's going to place your tongue outside the oral cavity. So when you squeeze this appliance in, a vacuum is created, and then you put your tongue into it, and that kind of pulls your tongue from the airway and keeps it open. So although it is very popular and is effective, patient compliance is extremely low. So this is how it would actually look on a patient. But a lot of patients have it's extremely uncomfortable. And the second thing is patients also have complaints of dry mouth. So a lot of patients really don't prefer using these devices. The third category of mandibular advancement devices are a combination of Cpap and dental sleep. Dental sleep appliances. So the combination is effective in the instance that it would reduce the positive airway pressure. So patients who are partially compliant but are not able to tolerate higher pressures, you could use combination of mandibular advancement devices and Cpap in such patients. So the basic idea behind mandibular advancement or oral appliance therapy is to decrease the duration of apneas, hypopneas, and raras. And it's also effective. It's also pretty effective in primary snoring. And the indications are mainly mild to moderate obstructive sleep apnea. However, in patients with severe obstructive sleep apnea who cannot tolerate the Cpap machine completely, or who do not respond to Cpap, oral appliance therapy is an alternative that can be considered. So in mild to moderate cases, it can generally be used standalone, or it can be used as an adjunct to your Cpap. So it does have a significant effect on AHI, although it's not as effective as Cpap. As you can see from this graph, oral appliance therapy is pretty effective in reducing apnea-hypopnea index. And it does have an effect on the mean systolic and diastolic pressure, which could vary from as low as -2 to up to 10 to 15. The main positive point of oral appliance therapy is its compliance. So if you look at a 1 year compliance, you would see at least a 50 to 100% compliance rate at 1 year. These are very small devices which can be carried anywhere. And patients who frequently travel, it's very convenient for patients to use these appliances. And if you see the success rate with oral appliance therapy, it generally varies between 45 to about 60% in mild to moderate cases. So comparing oral appliance therapy and Cpap, Cpap is definitely the gold standard that should be tried in all patients. In patients who are non-compliant or in patients with mild or moderate obstructive sleep apnea, what we see is that, although they are not as effective as Cpap with your AHI or your other parameters, the main area where they come into play is with the patient acceptance, tolerability, and convenience and adherence to treatment. So that with oral appliance therapy is definitely been found to be better than Cpap. So patients who are extremely non-compliant with therapy, dental sleep medicine is definitely an option that can be considered. So like I mentioned, what we see is that Cpap is definitely significant at reducing AHI and is definitely the gold standard that should be considered. But in patients who are totally non-compliant and patients who have very, very low adherence, you could definitely use oral appliance therapy in these patients. Recent advances, you also have auto-titrating mandibular positioner, where the dentist gives the tray that could be used by the patient at home at night, and it automatically titrates the tray, and this gives the bite to the dentist. So the dentist is actually able to directly titrate the mandibular advancement device to the optimal position based on the sleep study which is done at night. So so compared to before, where I said it was a trial and error, where we bring the mandible forward to 50 to 60% and then start titrating it in slow increments, this device directly determines the optimal position for jaw titration, and we can directly give the device at the optimal titration. So you also have the mandibular repositioning device, which is auto adjusting, and this again gives the optimal bite to the dentist so that they can fabricate the device directly at this optimal mandibular advancement. So the time that is taken for adjustment and for the results to be achieved is significantly reduced, and that increases the compliance. So sometimes patients, so in order to adjust the appliance and titrate the appliance, the patient needs to have multiple visits to the dentist and multiple sleep studies. So with the auto-adjusting mandibular repositioning device, all this is avoided, and this increases the compliance from the patient's perspective. So summarizing, the physician is the person who is the sole center for treatment of obstructive sleep apnea. The role of a dentist would be in either screening and referring the patient to the physician, or if the physician has diagnosed the patient with obstructive sleep apnea and has tried Cpap, the patient is non-compliant to Cpap, or if the case is a case of mild to moderate obstructive sleep apnea, and the physician refers him to the dentist, that is when the dentist would come into the picture. So once the patient presents to the dentist, we do a comprehensive history and complete clinical examination. And we also look at different radiographic evaluation, and we would recommend the best possible appliance. At this point, generally, we go in with the physician. We do talk to the patient, taken their considerations as well, and convey this to the physician. Once this is done, we decide the best possible device or the treatment, and we start with that. And we take patient consent and give the patient the appliance and then start titrating the appliance. We generally recall the patient initially at 24 hours, 48 hours, a couple of days, a week, 2 weeks, and then every month thereafter till the final calibration is achieved. At this point, we refer them back to the physician for a sleep study and evaluation of symptoms. After this, we also do check them periodically every month or every 2 months to make sure that there are no permanent occlusal changes. So dental sleep medicine is one of the most upcoming fields in dentistry. And in mild to moderate obstructive sleep apnea, they're very effective. The efficacy comes more with compliance and adherence to treatment. You could also consider it as adjunct in severe cases of patients with Cpap who are totally non-compliant to treatment. And recently available auto titration devices have increased the compliance and increased the efficacy of dental sleep appliances as well. So I'd like to thank the organizing committee and Dr. Bindu Kuti once again for providing me with this opportunity, and also my professors, teachers, and colleagues for all the help in getting this presentation done. Thank you. Any questions?
Yeah, I think you have looked into the chat box.
Sure, ma'am. I don't think we have questions.
Yeah, I think. Yeah, only compliments you have.
Okay, thank you, ma'am.
Yeah, very nice and informative talk, actually. Very good. Thank you so much.
Thank you, ma'am.
Thank you so much. We will look forward to see you online. I mean, see you sometime. And
sure, ma'am. Sure.
This is a very small token of appreciation.
Thank you, ma'am. I think there's just one question. Won't mandibular advancement devices change the face look? Generally, it does not because it's used only at night. And then you have morning aligners that you wear in the morning. But like I mentioned, mandibular advancement devices, which are used over a prolonged period for a couple of years, they can cause certain changes to the occlusion and facial look. But again, patients are more appreciative that they are free of their symptoms compared to the aesthetics. So many of the patients are okay even if it causes mild changes in facial form. But use of morning aligners has reduced that a lot. So generally, we do not see it immediately after treatment until a couple of years.